Have you ever wondered, why does it work that way? Or thought, how can we thrive with Medicare Advantage under these conditions? You're not alone. Jenn has wondered all those things and more. Every month, join Jenn Kerfoot and a motley crew of friends as they bring you candid conversations with industry pros, break down important updates, and share insider tips to boost star ratings. Whether you've been around since before Medicare had the advantage or are just starting out, there's always something new to learn. Welcome to Stars Unscripted.
Hi, everyone. Thank you for joining me for another episode of Stars Unscripted. I'm your host, Jenn Kerfoot, and this week I wanted to talk about some things. One, coming off the heels of being at HLTH in Vegas, but also as I've spent more time navigating these landscape files, I've noticed some interesting things. So last week, I think like 13,000 some odd people were in Las Vegas, and the irony isn't lost on us, or myself at least, that we are all in Vegas talking about the future of healthcare, meanwhile being surrounded by a lot of gambling and a lot of, seafood towers, etc. But I got to join an incredible panel with the CEO of Clever Care Health Plan, Karen Walker-Johnson, and Julian Harris, the CEO of Concerto Care, where we were talking about, one, is Medicare Advantage for everyone? And also, what does the future look like in terms of ensuring, the trust and the future of the program overall? It was only a 30-minute panel, so I didn't get to dive into a lot of the different things that I wanted to. And then I was flying home and looking into some of the data. A good friend of mine, Julia at Milliman, sent me over an article about their deep dive into the landscape files. I highly encourage everyone to give those a read. I think that they're super illuminating in terms of how we want to think about the next 5-10 years of the Medicare program. So to start, I want to paint two pictures. So one, 2025, Medicare beneficiaries have choices, not perfect choices, but choices. There's 464 standalone drug plans nationwide. There's multiple Medicare Advantage options in most counties, HMOs, PPOs, different formularies, different networks. Premiums went up, but members for the most part could shop around. I want to flash forward into the future, into 2026. So the landscape files, when they dropped, I kind of dug around in them, and since then I really dug into the data. So we're down to 360 drug plans. So that's a 22% drop in 1 year, and 6 Medicare Advantage organizations are completely shutting down, with 3 more pulling out of everything except their special needs plans. So that's about 310,000 members losing their coverage entirely and having to shop around for another plan. When I used to be at a health plan, and I used to be in charge of product and star ratings and a little bit of the risk adjustment teams, I learned that you got to read between the lines of these kinds of reports. And it wasn't to me so much the numbers, although that is important for this conversation. It's more the geography of this particular crisis. So in talking money, I want to start with that first, because that's really what's driving everything. Interestingly enough, Part B premiums have risen 38.1% since 2018, from $134 to $185. So that's faster than the 31.7% inflation rate for seniors. And looking at that, I like to do like that bottom-up approach, looking at it from the member's point of view. So for someone on SSI making $943 a month, so Medicare premiums now eat up about $247 plus or minus, and that's just average. And I use the state of California. So that leaves $696 for everything else: rent, food, utilities, medications, not covered necessarily. And so that's $696. So that's a lot. What's interesting is, like, where it really gets to me, like, kind of dystopian. Let's look at Vermont. So Vermont, an entire state, they're going from 3 Medicare Advantage carriers to 1. And some counties are going to have 0 MA options. So those are Americans who's going to wake up, if they haven't already, during AEP to find out they have exactly 2 choices: traditional Medicare fee-for-service, which a lot of folks can't afford, without supplemental coverage, or nothing, which to me just seems so odd, especially while we're seeing a lot of people tout that MA is for all, or we're going to have a program where all members have a choice. It kind of struck me as, what are the members that are getting choice, and what does choice constitute? So let's look at, like, I think California to me was really, really interesting, especially because that's where I started within the beginning of my career. And it's also, you know, a innovation capital as a state. So it has 16 rural counties where the median standalone drug plan costs $107 a month. These same counties have exactly one Medicare Advantage option. So if the plan doesn't cover your doctor, your cancer center, your cardiologist, too bad. You pay $107 just for drug coverage on top of your Part B premium. So formerly, like, I've sat in rooms, I've listened to other people who have sat in these rooms where these conversations about exit decisions are made. It always comes down to really margin. Like, can we make money here? If no, we exit. And, I've said a lot, the answer is in the name. It's called managed care. Don't take on what you can't manage. So I get that there is some market movement to shift back to core strategy. But, the spreadsheets can't capture 85-year-old rural Southern California member who's been on their medications for a decade, and they don't capture a cancer patient's oncologist that isn't remaining in the network. So what's really happening with these plans, PPOs are systematically being eliminated. And joke aside, or maybe not aside, it's known that I'm not a huge fan of a PPO. I think they're very difficult for a handful of reasons, from a network perspective, from a setting a member's expectation of what, a PPO is and what it isn't. 2026, we're down 70 PPO plans. So CVS, Aetna down 64, Humana 75, and they're not random decisions. Like, PPOs are expensive. Those broader networks, there's more flexibility. So there's seen in the numbers, we see higher utilization. And so they're being dwindled down, which is forcing the shift into HMOs with, narrow networks, prior authorization requirements and everything. On a side note, I'm not saying HMO or PPO is better. Eubin Park, go check him out on LinkedIn. He showed today really cool mapping of HMOs and star ratings. They actually carry the pack for having higher star ratings. But I think it's important to think about, that conversation around member choice. And so concentration is really, really staggering if we then shift to the PDP, prescription drug plan market. 96% of all members fall within just 5 carriers. And WellCare alone has 44%, which that isn't really competition. And or choice for that matter. And so when we start getting really nitty gritty into rural counties, you see that they have far less choices than individuals in urban counties. And so if we just look at the numbers and the current rate of decline, so since 2024, 31.3% of standalone drug plans have exited. And if you keep following that trend, it ends up by 2030, it's not that things get consolidated. It's not that it's struggling. It's that it's gone. And so it's interesting. I've never spent a lot of time thinking about, if you are on fee for service, but you don't have access to a PDP plan, what do you do? Where do you go? And the answer for, if we keep at this trajectory, will be just Medicare Advantage. And so think about that. If you don't want Medicare Advantage, maybe travel, you need specific specialists, maybe you just want choice. I pay my grandma $100 a year to not leave traditional Medicare with her Med-Sup plan, just because no matter how I map it, she can't get better coverage anywhere else. But, traditional Medicare becomes essentially unusable without drug coverage. It's a de facto forced migration into Medicare Advantage, and I think I get that, we see the reports from MedPAC and all the very different advisor groups really trying to create suggestions to stabilize, the overall market. But as we saw with the Inflation Reduction Act, Part D redesign, the federal government, went to pharmaceutical companies and said, if you want to, play in this game, you have to let us negotiate with you against, those prices to lower them for the American public. Conversely, that we see this in Medicare Advantage right now. Is the federal government going to say to MA plans, hey, these are the rules if you want to participate within the Medicare Advantage program? If you want to serve Medicare eligible beneficiaries, this is what you have to do. But one thing that is lacking is that the federal government doesn't say, if you want to participate, you have to participate across, rural areas, counties that are very difficult, counties with, not as big of, available networks. which I think is interesting as we think about the future of the overall program. We saw with the Medicare Modernization Act, it was, especially with, the risk adjustment program, it's that you can't, you know, cherry pick members to ensure you're only getting healthy members. And that's where we see, the risk adjustment program as it stands today. But is it kind of a de facto, or I don't want to use the word cherry picking because I feel like that linguistically kind of denotes like maybe a nefarious intent. But, if we look at where, members with chronic unmanaged chronic conditions live, or individuals with, high socioeconomic needs, or concentration of minority populations, those are in certain areas that just so happen to be also losing choice and losing their coverage options. So I just found that interesting. And I think it's important that as an industry, we bring that conversation to light, because obviously, like, I'm not smart enough to carry it on myself. I think people much smarter than me should be attacking this problem from left, right, center. Doesn't matter what side of the aisle you're on. I think it's an important question. And so, I think that at the end of the day, when I started making a list, which it was kind of like a very sombering thing for me to do, I started making a list of like who is the most vulnerable and who is harmed as this market, shrinkage and that consolidation, and some would say maybe collapse. Like, rural beneficiaries, they're losing options fastest. Many counties are down to just 1 or 0 MA plans, and their Part D premiums are the highest. For standalone Part D plans, and the provider networks are the thinnest. Second, we see like, middle income retirees. So like you're too wealthy, like the only thing worse than being poor is not being poor enough, in my opinion. So like for those middle income retirees, you're too wealthy for LIS extra help program. You're too poor to afford Medigap plus the standalone Part D plan. You've saved your whole life. You've paid into Medicare 40 years and they're getting squeezed out. And then third, I think, and this is something that we don't talk about enough, is the medically complex. If you need specific specialists, specific medications, specific facilities, like center of excellence kind of style places of care, it's good luck finding one plan that covers that all. And that PPO exodus means you can't even pay more for flexibility. But special needs plans are growing. So D-SNPs up 10% for 2026, C-SNPs up about 44%. Why? Because we see also in the data, you have better risk adjustment, accuracy and timeliness of risk adjustment, better overall star ratings, state contracts. It's kind of a system that's been born out of all of these market kind of forcing functions, where if you're poor enough or sick enough, you get options, but everyone else is kind of on their own. And Kevin at Milliman, great guy, helped me out with Rise West this year in a workshop. He did a great white paper on, the MOOP changes, and it's very similar data to what we're seeing here as well. Fewer plans, higher premiums, more concentration. Interestingly enough, I think when we're looking at overall exits, you have to think in the reality of your everyday average Medicare Advantage or traditional Medicare beneficiaries. A lot of members, especially older ones, they don't understand their options. They don't know how to compare formulas necessarily or evaluate networks. They just know that their plan is gone. And I think I think for an individual that's trying to navigate a bunch of things in their lives, especially in this economy, that's a very scary feeling. And I think that when prescription drugs are more expensive than ever, the insulin cap is nice, but what about cancer drugs, biologics, specialty medications? I know everyone wants to talk about Ozempic, GLP-1s, but like, let's talk about like basics. The Part D redesign was supposed to help these individuals, but it's actually driving plans out of the market instead. And honestly, like, having spent a lot of the year looking at this data, I cannot blame them. It is very difficult, especially for safety net health plans, to keep up. So Jen's prediction, I get asked a lot, like, you're looking into your crystal ball. What do you see? Like 2030 at this rate, traditional Medicare, I think it's gone. That's just what the trajectory is showing us. If it keeps up at this rate, especially with the Part D coverage, just going away. But without affordable supplemental coverage, it's just a really hollow option. And so Medicare Advantage is not necessarily going to be the best choice. I really think, and again, this is just my opinion, it's the only choice for anyone that isn't wealthy. And so when that happens, there's no competition, no alternative. What incentive do plans have to provide good coverage? What leverage do beneficiaries have, with the exception of, their vote? I won't get into that, but really, like, none. So some people I know, I've argued this with, say, well, MA has great star ratings, high satisfaction scores, but I think satisfaction is relative. If you've never had better, if you don't know what you're missing, if it's your only option, does satisfaction really matter? So geographic inequality is becoming Medicare redlining. So your zip code now determines whether or not you have healthcare choice. Like, live in Miami, just as an example, 20 plans to choose from, plus or minus. Live in rural Montana, you get one option if you're lucky. So I think it's important that we start thinking and having a conversation about overall member choice, and not just, do I get, silver sneakers, or do I get hearing aid benefit, but like real choice. So I think that a lot of times, when I'm lying in bed at night and my poor girlfriend has to listen to me, opine about it, like about the promise of Medicare. When it's created in 1965, it's a covenant with the American public and American workers. Pay in during your working years and we will take care of you in your retirement. No one said, we'll take care of you unless you live in Vermont or rural California if you can't afford supplemental coverage. No, it's a promise. Grow old, age with dignity, and we're going to take care of you because you worked. Traditional Medicare, Medigap, Part D model that millions of retirees planned on, save for, expected, it's priced out of existence if we continue at this trajectory. Part B going up 38%, Medigap premiums skyrocketing, and Part D plans disappearing. That three-legged stool, it just collapses in on itself. And so I think that at the very least, instead of talking just about market stabilization and strategic repositioning, we should just have a frank conversation about what abandonment is of these areas within our country. With Elevance exiting the entire standalone PDP market, that's not necessarily a repositioning. That's just, it's been disappeared. And I think the saddest thing to me really is the beneficiaries that are hurt the most are the ones that did everything right. They did what they were told to do. They did what, society says they should do. They worked hard. They saved money and they paid into the system. And now a lot of these seniors are being told the only option that they have is a plan that doesn't cover their doctor, or a premium they can't afford, or really no coverage at all. Because unless it's meaningful coverage, that's the value is recognized by that individual, I can't say that I would define that as coverage. And so as we look forward even farther into 2027, with CMS projecting more exits potentially, plans can't easily create new offerings, based on the crosswalk rules. And we see risk corridors are narrowing, the medical loss ratios are really squeezing margins, and every regulatory attempt to fix one problem creates really two new ones. And so at the bottom line really to me is, and what I wanted to really talk about with you all listeners is, Medicare is becoming a two-tier system. If you're very poor, very sick, you might have options through a special needs plan. If you're wealthy, you can afford traditional Medicare plus all, the accoutrements that come with it. But everyone else, that middle class, we got to talk about the middle class, the working retirees, the people that have, built this country, that have worked hard and worked so that they could, enjoy all the things that you want to do when you're retired. They're getting squeezed out. And, the Medicare Advantage penetration rate is over 50% now. By 2030, some people say it's going to be at 70% or higher, but not because it's better, but because everything else is going to be gone. That's not a market success. That's a market failure. And so, to be clear, this isn't about whether Medicare Advantage is good or bad. I like a lot of things about Medicare Advantage, and I have a lot of critiques about fee-for-service. And there are excellent Medicare Advantage plans doing great work. It was so inspiring to listen to Karen, the CEO of Clever Care, talk about how they think about their members, how they think about the future of the program and the future of their plans. You've heard me talk about Don Maroney at alignment and they take the stance of if you put people over profits, you shall profit. I also see this, a lot of work speaking the national plans as well, doing incredible work as well. So this is not a conversation about the good or bad or right or wrong in terms of the people running the current programs. I want to really make sure I say that for those in the back, but it's about choice. It's about, making sure we have geographic equity and affordable access. And I get it. The solution isn't simple. It requires a very difficult conversation that the current program, as we cross that tipping point, it doesn't meet the mark when it comes to scaling. It requires, policy intervention. And which I know the irony isn't lost on me that we're still in a government shutdown while I'm having this conversation, but it's important. It requires that recognizing that healthcare isn't a normal consumer good. So you can't shop for cancer treatment like you shop for a TV or a laptop. There's no consumer report for that. But we need to start talking about this because every person under 65 needs to understand that this is their future. Every current beneficiary needs to know that they're not alone in struggling with this. And every policymaker needs to hear that market exits aren't stabilization. It's the abandonment of their constituents from a system that is supposed to take care of them when they need it the most. Vermont going to one carrier isn't a small state problem. It's a preview. Rural counties with zero options aren't abnormalities. They're the future. Drug plans disappearing aren't market corrections. It's the system breaking down in on itself. The promise of Medicare, it's being broken zip code by zip code, plan exit by plan exit. And we have to start paying attention and start demanding better and start recognizing this crisis for what it is, or we'll wake up in 2030 with no choice at all. And it's just take what you're given or go without. And, I say this a lot, there's two bookends of our life. And it's two statements. When I grow up, I will. And a lot of people, myself included, are still figuring out what that is. And the last statement in the last bookend is when I retire, I will. That statement encapsulates a dream deferred. As you're listening to this, close your eyes and think how many times have you said, when I retire, I'm going to do this. I'm going to buy the boat, or I'm going to spend more time with my family, or I'm going to learn how to golf, if you like that kind of thing, or, just little things. And so you defer while you're working, that dream. And so how sad is it that when it's finally your turn to retire, sleep in, not worry about hitting that snooze and go, get after those dreams, you can't do it because you can't manage your chronic conditions, because you can't navigate a complex healthcare system. We're all of us the architects of what we inherit. One of the things that keeps me in this industry, that keeps me coming back to trying to think about, innovative products or innovative ways to solve, the challenging difficulties associated with our healthcare system, is that someday I'm going to age into this program. And I really, really hope that not only does it have $1 left in the trust for me, but also it's a system of choice, and it's a system that, makes sure that no one gets left behind. So thank you for listening to me today as I get out these thoughts and think about, the future. And I want to invite anyone who wants to, think about these things with me to shoot me a message on LinkedIn. And thanks for listening. I hope you all are having a great AEP. I hope that you're making sure to hydrate, spend a little time with your family, catch a football game, and take care of yourself. Because we need you, because it's going to take all of us to solve these types of problems together. All right. Thank you. Bye.
As a Medicare Stars professional, you're on a mission to boost your plan's ratings. But complex data and endless metrics make it more than challenging. Enter Stars Monitor by Hyperlift, your guide to improved performance. Our dashboards pinpoint your most impactful opportunities. By focusing on what truly matters, you'll avoid the pitfall of missed targets and achieve the goal of steady improvement. Take the first step towards your Stars success story. Email results@hyperlift.com for a free demo. Stars Monitor by Hyperlift, providing speed to clarity.